So we've been talking about these neuromuscular disorders. We've already talked about Guillain-Barré and myasthenia gravis, and I've used that term neuromuscular disease or neuromuscular disorder a couple of times. And what this is it's a generalized term that's used to describe disorders of the brain, the spinal cord, peripheral nerves, neuromuscular junction, and muscles. So it's a generalized term that's covering all of those different components. These disorders are typically associated with a range of motor and sensory deficits. However, patients with neuromuscular disease may develop significant cardiopulmonary issues, and that's why we're really covering this. In fact, breathing disorders are the leading cause of death when it comes to patients with neuromuscular disorders. It's really important for us as respiratory therapists to be familiar with these conditions and their effect on the respiratory system. So some of the additional neuromuscular disorders or diseases that we're going to talk about are spinal cord injuries, amyotrophic lateral sclerosis, muscular dystrophies, stroke, head injuries. Now, when we talk about head injuries, we're going to spend a whole lot more time on head injuries when we jump into traumas, but we're going to kind of get a good overview of these head injuries right now. Before we get into that, let's just go ahead and jump into the spinal cord injuries. So when there are spinal cord injuries, there is a significant increase in morbidity and mortalities. When we look at the National Spinal Cord Injury Statistics Center, the annual incidence of spinal cord injuries are about 18,000 new cases every year, and there's just about 275 or 288,000 living cases of spinal cord injuries in the United States right now. These statistics do not include patients who expired on site. The most common causes of spinal cord injuries are motor vehicle crashes, falls, acts of violence, and sport and recreation. No big surprise that guys are 78% of all of the new cases. This is typically from us doing, dumb things. We get super excited, we get around the boys and we think we're, high school heroes again, and we think we can do all of the things that we used to do and end up doing something really stupid and end up as a spinal cord injury. It could even be, the younger bucks that are trying to show out for the ladies and end up having an accident. We had, I remember a patient of mine that I took care of. He was on his honeymoon. He was honeymooning in Hawaii and went to do a backflip on the beach. When he did it, he did not rotate all the way and end up on his feet. He actually only rotated halfway and ended up on his head and had a severe spinal cord injury. Again, guys just typically are doing dumb things, and that's why we are 78% of all of these new cases. When we look at the spine itself, there are 3 different locations that are associated with these injuries. You have lumbosacral, you have the cervical nerves, and you have the thoracic cord. And this correlates with the lumbar, the thoracic, and the cervical spine. So all of those different areas of the spine will correlate with these injuries. So the lumbosacral is associated with the lowest part of the spine, and that's why it ends up impacting the lower extremities with weakness or even paralysis. You can have what's called spasticity, which is spasms in the lower extremities, and even the sphincters that control bowel and bladder movement. So you can end up with dysfunctional bowel and bladder. Moving up, we end up in the thoracic cord. This will impair the kind of middle portion of your trunk or your body, where you can have the lower extremities that are involved, and this can impact or hinder your diaphragm, which will impact the respiratory muscles that are involved, leading to diaphragmatic involvement, decreased cough, decreased ability to take a big deep breath, atelectasis, alveolar consolidation, things of that nature. So when we look at the cervical nerves at the top of the spine, what we're talking about is the C3 through the C5. If we have significant involvement of the cervical nerve C3 through C5, you're going to get an impairment to the signal that sends communication to the diaphragm via the phrenic nerve. So the phrenic nerve is going to be impaired or impacted when it comes to the signals to the diaphragm. If you have any sort of involvement from the C5 and up, so we're talking C1, 2, 3, 4, and 5. If it's C1 or C2, you're going to have respiratory compromise, which they will not be able to overcome. They will be on the ventilator for the rest of their life. Most of the time, this will end up with death if immediate intervention is not taken care of. But if we look at C3, C4, C5, these can still result in significant respiratory compromise if these are not taken care of, and ultimately even lead to death if those are not taken care of right away. Other impacts when it comes to spinal cord injuries, you're going to have the rib cage that stiffens after a few months of having a spinal cord injury. This results in a decrease in the respiratory compliance or the thoracic compliance and an increase in atelectasis, with an increase in compliance to the abdomen, which leads to patients with cervical or thoracic injuries. They may develop this rapid shallow breathing pattern, or what's called a paradoxical breathing pattern. Where else did we see paradoxical breathing? Not necessarily associated with the abdomen, but with the rib cage itself. But this paradoxical abdominal breathing pattern is kind of showing that the chest wall moves inward during inspiration, not expands, but it moves inward, and your belly starts to expand because of this isolated diaphragmatic breathing. You're not getting any additional help from any of the other respiratory muscles. So you end up with this autonomic dysfunction that is commonly associated with these spinal cord injuries, and can actually manifest into hypotension or hypertensive crisis and even tachycardia. So you start to get autonomic dysregulation from this as well. So when we look at this, the American Spinal Injury Association, or ASIA, impairment scale classifies the extent of spinal cord injuries with the following categories. And I'm not going to read this to you, but it is through an A through E factor. And when we look at this, your A is going to end up being your worst cases that are out there. When we look at the E, these patients are going to have an incomplete or sensory and motor functions are normal. So your A's are your worst, and as they get better, they have a more advanced in the alphabet. When we look at the diagnostics that we would typically look at is going to be a chest x-ray, or not necessarily a chest x-ray, but you would get a neck x-ray. You could get a CT and even an MRI. And what we will see when it comes to the x-ray, sometimes you can have tissues or structures that are obstructing your view, and you want to use a CT, because what that does, as we talked about it, remember, it's like that ruler, and you have slices of a loaf of bread. And if I wanted to pull out an individual slice, I can see that with a CAT scan or a CT. When we look at MRIs, the magnetic resonance imaging, MRI, is much more sensitive and better evaluates the spinal cord, nerve roots, ligaments, and disc spaces compared to the CT or even the X-ray. So as we look at this, X-ray would be the lowest level that we would look at. Then we would go to CT, and if we wanted our highest level of sensitivity, we would look at the MRI. So when we're looking at this, when we have patients that come to us with a C-spine injury, one of the things that we have to do is we have to stabilize that C-spine, because if there's any sort of dysfunction or dysregulation in the C-spine, it's going to automatically impact the phrenic nerve, which sends the signals down to the diaphragm. So we use collars, whether it's a C collar or an Aspen collar, the collars that you see most trauma patients come in with. This is to stabilize the C-spine until that's cleared by either the physician or a radiologist that's reading a CAT scan or an x-ray. We want to get these patients surgery as soon as possible. Sometimes we have to kind of delay if there is swelling in tissue. If there's a swelling in tissue, we have to be mindful that we have to let that swelling go down so that the surgeons can access the appropriate sites for surgical interventions. When it comes to the autonomic dysfunction, remember this is your automatic system. You could end up with hypotension or hypertension and tachycardia. Well, a way that we want to avoid the hypotension is we're going to use IV fluid resuscitation. When we talk about resuscitation, what this is giving that patient plenty of fluids so they are not hypovolemic. We can use vasoactive medications. We're starting to see these in the ICU already. This is your Levophed, your dopamine, your dobutamine, your neosynephrine, all of these different medications that are used for vasoconstriction. We can look at anticoagulation, and we're going to evaluate the rectal tone. What this does is this evaluates, do you have control of your sphincter tone? If you do not have control of your sphincter tone, then we know that there is some sort of spinal cord injury. Typically, it would be thoracic or lumbar spine, but it does not have to be isolated to those two areas. We will do what's called a barrel roll, and a lot of times as respiratory therapists, we are at the head of the bed and we are controlling that C-spine. So we hold the head in a neutral position, and as that patient turns, as they roll, we keep that C-spine and that head in a neutral position so that the spine can be evaluated, so that this rectal tone can be evaluated as well. Part of our job is to control the airway. With controlling the airway, we have to maintain that C-spine. Other things that we want to look at, again, if it's a C5 and above, these patients are most likely going to need some sort of respiratory support, whether it is positive pressure ventilation, bagging them, non-invasive ventilation, or they get fully mechanically ventilated. You're going to have an intubation if these patients end up on mechanical ventilation. Remember, we've got to keep that head in a neutral position. So it's going to be really hard for us to get them into that sniffing position to open up their airway. So we have to be able to keep that patient in that neutral head position while we access their trachea. We talked about the mechanical ventilation. Sometimes we end up with what's called diaphragmatic pacing, and these patients can end up with long-term pulmonary rehab. So lots of impacts when it comes to C-spine involvement with spinal cord injuries. The next thing that we're going to look at is ALS, or Lou Gehrig's disease.